Hello and welcome to another edition of Cardiac Imaging Agora. My name is Wael Jaber, my colleague Alessia Gemelli. Alessia is a fantastic friend. She's joining us today. She's my co-conspirator for this program. Alessia, we started this, 3 weeks ago? As a great idea you had. And now, 24, 25 programs are up and loaded with over 1,400 viewers, I think, as of today. It's phenomenal success. Thank you for the idea. It's such a joy to join you. I know we're 6 hours apart and 3,500 miles. And today we're going to do just a session on basically very short cases, knowing that most of imaging is pattern recognition. So if we recognize the pattern, then we'll call it right. So this is, Alessia prepared this. It's called Train the Brain. And she's going to try to quiz me on how to do this. Alessia, please.
Oh, thank you very much, Val, for this nice presentation. And thank you very much because your help is in your role is mandatory and fundamental in this experience that we are having in Cardiac Imaging Agora. So thank you very much. So this evening in Italy, we are trying to prepare something for Train the Brain. And so I would like to share with you some cases. The first one is a case of a man. And he arrived at our attention for dyspnea on effort and atypical chest pain. He had hypertension, hypercholesterolemia, and history of asthma. So he has also a chronic obstructive pulmonary disease. And he has moderate physical activity due to the fact that it's a waiting list for hip replacement. So he was submitted to an echo, but due to a poor acoustic window, we are not able to evaluate very well his function, even if apparently there is a normal ejection fraction. So what does we can do? We can submit him to myocardial perfusion scan. And so this is the result of our myocardial perfusion scan.
In this instance, what we have here is a SPECT scan. These are the rest images on the bottom, the stress images on the top. And we again, I'm glad that it's a universal way of displaying the images. The way I look at them usually is the way you're displaying them. In the rest images, if you look at the middle row right here, you can see almost nice uniform uptake in the entire left ventricle, no significant problems, a little bit of resolution issues because this guy is COPD or heavy guy, risk factors. And then with the stress images, you can see this perfusion defect. It's in the moderate to severe range involving the apex, apical septum, apical inferior wall. Again, you can see that here in the short axis, although we're not seeing the apex very well here. And again, on the polar maps, you can see what we just described. A little bit of a problem with the images in the rest scan because of, again, attenuation known to happen with SPECT. But everything in the distal LAD territory is worsening. And you can see the display here with a sum stress score of 14 and some different score indicating ischemia of SDS of 12. So this is a very positive test to my mind with LAD ischemia.
Absolutely, but we can also observe the evaluation of function. Because in this case, it's important also to observe that there is a reduction in terms of absolute ejection fraction after stress. And we generally acquire it very close to the ischemia time. We perform the stress first and then rest. And we acquired it with the sort of ultra-fast protocol, 15 minutes after the end of the stress and the injection time. So in this case, we are able to evaluate the real stunning of the heart. So it's very important. It's very nice in this case because you can observe that there is a reduction of ejection fraction after stress and about 6 points in terms percentage from rest scan, and there is also an increase of volumes of end-diastolic volume as well as end-systolic volumes. And more than this, and finally, there's also a reduction of diastolic function evaluated by the peak failure rate. So in the ischemic scale, we have all the points that are covered with this kind of SPECT scan, because we have the reduction of perfusion, we have the reduction of diastolic function, and we have also the reduction of systolic function. So we can say that we have a high-risk patient, probably yes. So the question is, for our audience, which is the best interpretation of these images? Are we in front of a normal scan? Have we have ischemia and stunning in one vessel disease, or in two vessel disease, like for example, LAD and LCX, or we have only ischemia and three vessel disease? What do you think?
So if you go back just one slide, if you don't mind. So this is actually extremely important. So we have all markers of a high-risk scan, despite this relatively small size of the perfusion defect. So you have perfusion defect in the LAD territory, but as you mentioned, there is a drop in ejection fraction and TID with end-systolic and end-diastolic volumes increasing with stress. One of the important things we don't look at very often in the US as much as you guys look at in Europe is this parameter of end-diastolic volumes per second change. And this is exquisitely very good for diastolic dysfunction, especially if you image at a high frame rate. So most labs do 8 frames per cardiac cycle. We do 16. I don't know what you guys do in Italy, but what is happening here simply is this is the shorter the number, the worse it is. So here you go from 54 at rest to 48 for EF and 2.4 to 2. So all these things, Alessia, as you mentioned, are markers of a high-risk scan for me. If I'm seeing this and I have to bet, I will bet on multi-vessel disease, although the defect is in single-vessel disease.
Yes, I agree with you. In this case, however, we are in front of ischemia on LAD. So this is a CZT scan, so with a high resolution scan. So when we are in front of this kind of perfusion defect, like in this case, we don't forget that we are in front of a very sensitive camera with a resolution of 4 millimeters. So we are able to evaluate patient with 3 vessel disease. And in this case, the defect is very closely related to LAD. So even if we can be in front of a patient with 3 vessel disease, in this case, the correct answer is LAD plus stunning. So this is a very high risk patient because at the end of the scan, we submit the patient to coronary angiography because at the end of the scan, he had also angina. So typical angina. So he was submitted to coronary angiography to revascularization of the LAD.
This is a fantastic case. You know, I admit my my ignorance at our institution. At least we do not have a CZT scan camera, so we use SPECT, traditional SPECT with a CT attenuation correction. Phenomenal images for a person with this profile. Thank you.
No, thank you very much. It's very important for us to discuss. This is the case number 2. We are in front of another man of 61 years old. And again, we are in front of a man with a typical chest pain and with a dyspnea on effort. He has hypertension and dyslipidemia. And at echo, we evaluated a normal biventricular function. So he was submitted to myocardial perfusion scan. And this is the results. He performed, in this case, really an exercise stress test of 150 watts for 2 minutes with a very high rate pressure product. And there is no ST abnormalities, but you can see here that the summit stress score was 6 and the summit rest score was 0. Apparently, there is no big difference in terms of change in volumes and ejection fraction. But what about the results of perfusion scan?
So again, this is a very, very nice images, beautiful images actually. So the rest images are on the bottom, the stress images are on top. So if we start reviewing this here, because we see almost all the way to the apex, the short axis at the rest images is almost normal. I wouldn't say they're completely normal. There's a very mild perfusion defect in the inferolateral wall right here. You see it again right here compared to the septum. Now, usually I don't make a lot about, about this issue, because in patients who are older, they tend to have septal hypertrophy or LVH, and that sometimes you can see this increased uptake in the septum versus the lateral wall, where just traditionally you see more uptake in the lateral wall because it's closer to the gamma end of the septum, except if you're using attenuation correction, that's a different story. But when you go from rest to stress, you can see significant decrease in counts in the stress images right here. Inferior, inferolateral, basal, and mid. It does not extend to the apex. And you can see it very well on the short axis images here, very well described here in the polar maps. So very mild defect at rest. I will probably dismiss it, as you said here, as 0 because of this increased uptake or high counts in the septum. But again, this would be, for me, I would describe this as a moderate perfusion defect in the circumflex territory.
Yes, and in this case, again, which is the best interpretation? So the answer is, in this case, very clear, and I fully agree with you. We have an ischemia in one vessel disease like LCX. So perfect, Weil.
Sometimes I get it right.
So for case number 3, we have another man of 65 years old. Again, we had a patient with dyspnea on effort, but in this case, we have typical chest pain and hypertension and dyslipidemia, normal ventricular function, and he was submitted to an myocardial perfusion scan for the evaluation of inducible ischemia. And in this case, really, we have in presence of regadenoson stress test without presence of symptoms or ST abnormalities. But would you like to evaluate this case?
This is again a nice, so they have a couple of things that I paid attention to or I found here very quickly when I looked at the scan. First, let's look again at the short axis and the rest images. You can see a mild to moderate perfusion defect at rest involving the basal lateral wall, basal anterior and inferolateral wall right here. You can see it right here too in the horizontal long axis, nicely on the rest images. Now with stress images, we have a few things that happen. First, this defect becomes severe, and now it extends all the way to the apex of the lateral wall. You can see it nicely here, all the way up to the apex here. And now you can see also some extension to the basal inferior wall right here in the vertical long axis images. With that also we see some, at least visually, there's LV dilatation, it gets bigger. And one more thing, which is if you look at the images right here in the horizontal long axis, you can see increased RV uptake. So we have a lot of signs of multi-vessel ischemia. So we have, I would call probably, if I have to read this, I would call ischemia in the territory of maybe the circumflex coronary artery because the inferior septum is not involved, and probably LAD or LAD diagonal territory. With the RV dilatation, I would call this as a high-risk scan. The other thing that you showed me here is the drop in ejection fraction for rest to stress, again confirming the dilatation and the worsening of diastolic dysfunction. So all these things are in favor of a high-risk scan with at least multi-vessel ischemia. So what's the question?
So the question is, we have ischemia in one vessel disease. on LAD plus stunning, in one vessel disease on LCX plus stunning, or in two vessel disease, LAD plus LCX plus stunning. And in this case, we have ischemia in two vessel disease, LAD plus LCX. So wonderful. You are really wonderful, because this is a high-risk scan. Absolutely agree with you. It's completely different from the previous one. And so we have a drop in the ejection fraction, and we have a drop of diastolic function. But you see that it's completely different from the first one, for example, where the extension and the severity of the perfusion defect is completely different if we analyze this scan with the previous one. So two different cases, but very high risk patient in both cases.
One thing that's very interesting, thank you, this is a great case. And what at one time, maybe about 15, 18 years ago, when I was younger and happier, so we had a research protocol where we imaged those patients at peak stress, both with nuclear, where we were doing this with PET, and with echo. And what you find in these patients, especially when they develop circ ischemia like this, profound circ ischemia, they develop ischemic mitral regurgitation. And therefore, that's why sometimes you see these patients, the left ventricle dilates and the RV uptake increases. And that's all due to ischemic mitral regurgitation and like almost pulmonary hypertension, acute pulmonary hypertension. It's fascinating to see this, because you expect this amount of ischemia to cause ischemia of the papillary muscles, and therefore ischemic MR. And that's why these patients get short of breath on presentation most of the time as the initial presentation. Fascinating case. Thank you.
Oh, thank you very much. And so we have case number 4. The case number 4 is a female of 70 years old with a typical chest pain and dyspnea on effort. So all these cases apparently are the same, have the same symptoms, but completely different cases, with hypertension, dyslipidemia, and diabetes, with a BMI of 31. So she's a little bit obese. And also in this case, we have a normal biventricular function, but we are in presence of right bundle branch block. So she was submitted to a myocardial perfusion scan. Also in this case, we use regadenoson. So what do you think about this scan?
This is tough. So let's start with the rest images.
Yep.
So the rest images, short axis appears to be normal. So in this side of the, on this side of the Atlantic, we eat donuts and bagels. So the bagel and the donut are completely normal. All no problem here. On the stress images, now we see a perfusion defect in the basal inferior wall. I can see it in almost all the, you can see it right here. I'm trying to see if I see it right here, and I see it right here. Very limited to the basal inferior wall, and maybe basal inferior septum right here.
Yes.
It's very hard to call this defect.
So
this
also
is a female.
in terms of quantitation, it's the Somerset score is very low because it's 2.
Yeah. Very hard. So even if I call this positive, this will be a low risk scan given the amount of myocardium at risk. So we usually start worrying about these scans as being, more than low risk when the SDS or SSS score is above 4. And here we have 2, very mild defect. In a female, it's very hard to explain this. I would have loved for this to be on the rest images and then the stress images normal. Then I would say, even in a female, if she had a mastectomy, or she would have probably a diaphragmatic attenuation. But I would call these defects and still call it a low risk scan. I know this is not a satisfactory answer, but this is real life.
Yeah. And so also in this case, we can have normal scan, ischemia in one vessel disease, like LAD or RCA, or ischemia, for example, in a 3-vessel disease. We could be in presence of balanced ischemia. But this last, But in this case, the last, probably last answer should not be the right one, because we are in presence of normal function both at rest and after stress. So it's very difficult. And so you see, we are in presence of normal scan. Normal scan, and we can say that sometimes, especially in young female, or in female, young or not so young, in this case we are in presence of an old female, we are in presence of microcirculation abnormalities. So we don't forget that one of the causes of ischemia is not only the presence of stenosis on the main vessel, but it's also presence of microcirculation abnormalities. And so we do not forget this very important point.
So this, she had normal epicardial vessels, but has abnormal microvascular response. And,
yes.
And this is, again, you read these things, you know, as much as I do, probably more than me, because we do a more PET here. This is the nightmare of any doctor seeing those patients, because first, you didn't have a real exercise test. This was regadenoson, right?
Yes.
This was down with regadenoson. So you don't, sometimes when you do treadmill stress test or bike stress test in Europe, a lot of the information you get to reassure you that things are going to be fine from the stress test, because the patients, if they achieve 8 meds, 10 meds, they go long on the treadmill. You say, okay, you know what? I saw some mild ischemia, but I don't know. But with regadenoson, I see this, but I would have read it exactly the same. A very mild abnormality, and but again, it's difficult. Thank you.
Yes, absolutely. And the last one, we have a patient of 58 years old with a worsening of dyspnea. We are now in presence of a patient with a dyspnea of NIA class 3. He has a previous anterior myocardial infarction, was treated with the PCI and stenting of LAD. Again, hypertension and diabetes with a BMI of 30. The EKG showed an QS from V1 to V5 and an ejection fraction of 45% with the kinesia of the apex distal portion of the anterior wall and inferior wall. So he was submitted to evaluation of inducible ischemia and extension of necrosis. This is the scan. So you see that it was submitted to an exercise stress test, and incredible. You reach a very high rate pressure product of 31,000. And this is the results of the scan. Could you comment the scan?
So when you're going in that this is going to be a perfusion defect, knowing what you saw on the EKG and the echo, so this is not unexpected. So if you look at the rest images here, you see this distal LAD, apical perfusion defect. The left ventricle appears dilated. Again, if you're reading these scans, for those who just start reading this, always use the same magnification. Don't try to play up and down with it. That way, when you look at it immediately, you know exactly what you're looking at, rather than every time you look at it with different magnification factor and you don't know what you're looking at, dilatation or not. So always pick whatever magnification you want to look at it, and look at it all your life like this. Now, the second way is to look at this perfusion defect. Appears to be, to my eye, so far fixed, except for this small area right here, a little bit of ischemia, but in probably right here too, just tiny bit of ischemia. But this looks like a predominantly fixed defect in the distal LAD with left ventricular dilatation. Again, you can see the ventricle is dilated. The ansystolic and diastolic volumes are high, with a reduced ejection fraction. But I don't see much ischemia here. Predominantly is a predominantly fixed defect. Just a small amount of ischemia, if anything.
Yes, there is also a little drop in terms of ejection fraction, but this probably is due to the fact that this is a patient with a big area of necrosis in the apex. So it's not uncommon in this kind of patient. So also in this case, which is the best interpretation? So normal scan, obviously not. Ischemia in the LAD territory, no. Not. Ischemia and necrosis, probably not. I fully agree with you. we are not in front of big area of ischemia. Probably if there is some ischemia, it's very, very close to the border zone of the necrotic area. So the right answer is necrosis on the LAD territory. And here we have also the magnetic resonance of this patient. And so you can see that the area of necrosis is very similar to those obtained by the myocardial perfusion scintigraphy. So we are in presence of a patient with a previous myocardial infarction, but no absence of inducible ischemia at a very high rate pressure product. So it's a very low risk patient in this case.
Do you mind if I ask you a question? So for us, a lot of these patients will end up having PET FDG. How do you assess viability in your lab? Do you do it with thallium or do you do it with nitrates? How do you do it?
We use nitrates. We use nitrates previous the rest injection because so as you can read in the previous published literature, there is no big difference in terms of evaluation of viability if you use nitrates plus tetraphosphine if you compare with thallium. So it's the best way in order to reduce also the radiation exposure in this kind of patient, because the use of thallium is avoided in order to reduce the radiation exposure. So in this case, for example, the total amount of dosimetry is lower than 4 millisievert with this kind of technology. So it's very nice. For example, in case of normal scan, if you perform the stress first, like we do, and so we can obtain a normal stress scan with a dosimetry lower than 1 millisievert. That's incredible.
So what dose of tetraphosphine you use?
We use generally for stress first, and we use around 120 megabecquerel. It's around 3.5 millicurie.
Wow. And so these are only, you could do these protocols, of course, if you have a CZT camera, right?
Yes.
Yeah,
yes.
And with the ultra-fast protocol you use, this is, again, not widely available in the US, unfortunately. We still have, the problem with when you purchase equipment is you purchased at a high cost, and that cost, you have to average it over the years. So you end up having a camera, although the technology keeps moving, you still have the camera you just bought 5, 6, 7 years ago, whatever the technology was. But these are fantastic images. Just one question, how do you do because we don't do, in the US, most centers don't do nitrates. So you bring the patient, you do a rest dose, a rest image, with the same dose for the rest, for tetraphosphine.
No, you double the dose.
Yeah.
You double the dose. We use a 1-day protocol. So we performed stress first, and then if a rest scan is needed in presence of myocardial infarction, for example, every time is needed. So we evaluated the pulmonary artery pressure, the arterial pressure of the patient, because it's mandatory in order to avoid a drop after nitrates. And then we use oral nitrates, for example, carvazine, sublingual dose, and we wait for the hemodynamic effect, and then we injected the rest dose, that is double the dose of the stress. So in this case, for double or double and a half. So in this case, for example, 3.5 millicurie, and at rest we injected 7 or 8 millicurie. So at the end, we performed a 1-day stress rest protocol in 2 hours, and with a dosimetry lower than 5 millisievert.
How soon after you give the nitrates do you image?
Sorry?
After you give the nitrates, how soon do you image the patient? Do you put them on the camera?
Half an hour.
Half an hour. Okay.
Yeah.
Fantastic. This is very informative. Thank you, because we don't do these things, and you never hear them being discussed, at least in North American meetings. These are great cases. Thank you.
Yes. Oh, thank you very much.
All right. So with this, we conclude our session of Cardiac Imaging Agora. I thank my colleague and friend Alessia in Pisa.
Thank you.
I wish I could be with you. and we'll see each other very soon. Have a great day. Thank you for listening to our and watching our program.